the bread and butter of a pain management guy is epidural steroid injections. That's what you're going to do. That's what you're expected to do. And medial branch blocks, very, very, very basic. So let's keep it basic. Once again, you know, my favorite quote. Let's start with the epidural steroid injection. Why do you do epidural steroid injections? It's the most common interventional procedure performed for low back pain. What are the indications? Why do you do a lumbar epidural steroid injection? One, lumbar radiculopathy is the best indication for an epidural steroid injection, right? It is the best indication. If somebody has radicular pain going down the leg, the epidural steroid injection is the best option. Spinal and foraminal stenosis. Someone was asking this morning about spinal stenosis. Does it work? Yes, it does. It does work in spinal stenosis. It all depends on how narrow the spinal canal is. If it is way too narrow, probably not. But if they have neurogenic claudication, yes, it does work. Foraminal stenosis are also degenerative disc disease, disc tears. If there's an annular tear in the disc, epidural steroid injections go and heal that tear. Protrusions, herniations, neuropathic pain, herpes zoster, good indication. Postherpetic neuralgia, good indication for the epidural steroid injection in the distribution. Let's say they have herpes zoster and L1-2 distribution. Do an epidural steroid injection at that level. Works well. Vertebral compression fractures, it does help some. It's not a good indication, but it does still help. When do you do caudal epidural injections? Failed back surgery syndrome. Somebody has had a back surgery, as Anand was saying this morning, don't stick a needle through a back incision because you're going to go into the intrathecal space because the surgeon has already violated your epidural space. So you're going to get into the intrathecal space. So avoid the scar and go caudal. The lumbar epidural steroid injection can be performed using two approaches. One is the interlaminar, right? And one is the transforaminal. And the other one, of course, is caudal, whose lumbar anatomy is distorted because of back surgeries. I think we saw this slide this morning. This one is transforaminal. That's the foramen there. Interlaminar, and that's caudal right there. Okay? So, if you can look at the pictures here, this picture was also shown in the morning. I'm just going to run through this really quick. This is translaminar or interlaminar, it doesn't matter, because you go between the two lamina, that's why it's called interlaminar. And then this is transforaminal. You can go into the foramen, the tip of the needle is into the foramen. You can see the nerve root nicely, right? What nerve root is that? Yes? L5, right? So that's the nerve root. Once again, basic anatomy. Anatomy always will haunt you. So the spinal cord ends in most people at L1 or 2, right? The epidural space is bounded anteriorly by what? The posterior longitudinal ligament and posteriorly by the vertebral laminae and ligamentum flavum. The epidural space has fat, veins, arteries, lymphatics, and nerve roots passing through. Once again, if you have this in your mind, the anatomy, we talked about all of this morning. I'm not going to repeat it. It's just a nice Netter's. And guys, who of you has the Netter's Atlas? Everyone should have. Every practicing interventional pain management physician should have a Netter's because it's an amazing atlas. This is from Netter's with permission. So Netter's is awesome. It teaches you anatomy very well. And relation of the spinal cord. It's one important point that you can see here is look at this picture here, right? So this is L4, this is L5. There is a herniated disc right there. And if the herniated disc at L4, 5, guess what nerve root is it going to push on? It's going to push on the L5, right? L4 takes off right there, below the pedicle. It takes off below the pedicle. So usually L4, 5 disc herniations don't compress the L4 nerve root. They compress either the L5 or the S1, S2, S3, or S4 nerve roots. If it is more a central herniation, all these nerve roots can be affected, leading to sometimes to cauda equina syndrome, right? But the L4 is almost always spared. Unless it's a far lateral herniation and it presses in the foramen, it's usually the L4 is gone by that time. Then the L5 is the one that is affected. This is S1 right there. That's L5, S1 disc herniation. So once again, anatomy, 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 and anatomy. So we've talked about this. Anand's done a good job this morning. The anterior compartment consists of the vertebral body and disc. The middle compartment has the spinal canal, and the posterior compartment has the facet joints, the transverse processes, and the spinous processes as well. So that's how it looks like. Kind of fancy colors there. You look at the spinous process, the lamina, and that's the pedicle, and that's the vertebral body, and that is the transverse process, the superior articular process, and anterior to that is the anterior compartment, posterior to that is the posterior compartment, and the middle compartment is the spinal canal. And this is a picture again. If you can look at the pedicle, that's the pedicle. The orange is the pedicle, right? And then your nerve root comes right like that, like so. This is the lateral view. What is this? This is the two laminae joining together, right? And forming the spinous process. And these are the places that you look for to go into interlaminar. If you want to do an interlaminar epidural steroid injection, you're going to get the needle in there, right? That's where you need to get it. Those are the spaces right there. Once again, comes back to Netter here. It's L4-5 disc herniation. So if there's an L4-5 disc herniation, it can affect the L5, S1, S2, or S3 nerve roots. The L4 is spared. What's that? That's the pedicle, right? The highlighted part is the pedicle. The L4 nerve root, fancy stuff. L5. That's the transforaminal, where you go to block the L4 nerve root, right there. L5 nerve root that's where you block if you go transforaminal. What are those? Spinous processes. What are those? Pedicles. What are these? Nerve roots, right? Exiting nerve roots. Exiting nerve roots, they go right below the pedicles, like so and like so. That is the transforaminal, right? That's where you put the needle for the transforaminal. Transforaminal. This is the lateral view. What are those? Vertebral bodies. Those posterior elements, right? All the posterior elements together, bunched together. The transverse processes and the spinous process is what you're seeing, because you're seeing it on an end-on view here. So, what are those? Pedicles, right? What is that? That is a longitudinal ligament. That is the anterior surface, anterior border of the epidural space. And this is the spinal canal, right? That's the spinal canal. That's where your needle should go. It should not go any beyond that. How do you do the epidural steroid injection? You have video demonstrations tomorrow. There is a video demonstration station where you can see the procedure, me performing the procedure. I'm not going to go through all the steps, but the basic steps: patient is placed prone and skin preparation is done. The fluoroscopic picture of the lumbar spine obtained in the AP view. Always first get the AP view, which gives you the what? It gives you the direction. Adjustments in the angling and rotation of the C are made till interspaces are optimally open. Once again, position, position, and position. So position your fluoroscope appropriately and angle it appropriately to get the interspaces open. Don't fight against a closed space. So open the space up. You use the fluoroscope to open the space up. Desired interspace is identified, skin entry point marked in the interspace, preferably on the affected side. So let's say if a person has a herniated disc with radicular pain going down the right side, which side are you going to put the needle on? On the right side. You don't put it on the left side, correct? So you put it on the right side. A 2V tip needle is used. It is advanced under fluoroscopic guidance under direction, depth, and direction technique in both AP and lateral views. So let's pick this here. Spinous processes. What are those? Laminae, right? What is that? That's the space you're looking to go, right? So let's say this is L5. Everyone agree this is L5? This is L4, right? So what is this space? You'll be accessing the L3-4 interspace there, right? So what is this space? L4-5, left and right. L5-S1, right? That's where you go if you want to do the epidural injection at L3-4 on the left side. What is this level? L4-5 on the right side. What is this level? L5-S1 on the left side. That's the space you're looking at. You can actually open up that space much better. If you tilt your full fluoroscope, you can open that space up much better. This is the 2E epidural needle that you're going to use for an epidural steroid injection. So what are the structures encountered? We talked about it, right? The skin, subcutaneous tissue. What is the next structure? Come on, guys. Next. Next. Okay. What's that? What is the orange? Supraspinous, right? What is that? Ligamentum flavum, right? So there you go. So you start your needle here. That's where you go. Right? That's the lateral view. This is a kind of a, you're looking at from top this one. So that's where you go, and that is the epidural space, and it can spread. Remember one thing, guys, the epidural space is a cylindrical space, right? It's not only in the posterior aspect, it's also in the anterior aspect. So when you deposit the medication, it goes all the way, it goes around. So you got to remember that. You all know what loss of resistance is, right? So when you put the needle into the skin and then you enter the supraspinous ligament, you get resistance. And once once the tip of the needle is in the interspinous ligament, a loss of resistance syringe is attached. What is this one? This is made of plastic. What is this one? Glass. Which one is better? Neither. The one that is better is what is better for you, right? Because your thumb is different from mine, your forefinger is different from mine. What you feel is different. So let nobody tell you that glass or plastic is better. You pick what is better for you, right? क्या बोलते हैं? सबका सुनना, अपना करना, right? So that's what it is. So because you are doing the procedure, right? Not somebody else. Somebody else may say the glass is better, right? No, you pick what you want, but pick one, and then you can stick to one. I do with both because I have to teach. I teach all the time. So I use both. I like both. My preference, glass. But that doesn't mean your preference should be glass. So it can be one or the other. Air or water, which is better? What you like, right? What you like is the better, please. Because you are doing the procedure for God's sake. No, don't let anybody convince you that, oh, saline is better. Oh, so what is the advantage of saline? Pushes no, it doesn't. So, it pushes the ligament away. No, it doesn't. So that's not the point. The point is what you like, what you feel. So you choose what is good for you. What is good for your tactile feel is what you pick. So the needle advances. Oh my goodness. Okay. I guess, yeah, anyway, that was beyond the point. So the needle goes in all the ligaments and it enters the epidural space right there after loss of resistance. The pedicles, the posterior elements right there, and vertebral bodies, and then the needle goes in there, and guess what? That is the, what is the dye showing you? What is the dye showing you? That is the nerve root, right? That is the nerve root coming out. That's the nerve root on the lateral view. So once you know where the tip of the needle is, now you have done the loss of resistance, you know, you think you're in the epidural space. So what do? You aspirate and see if anything is coming out. What do you expect to come out? Nothing. Air, right? Air. And then you inject dye. What if fluid comes out? Where are you? Yeah. So then you inject dye, and the dye spread should be in the epidural space without intravascular. Very important, guys. Very, very important. When you inject the dye, if there is a whoosh and the dye goes away, that is arterial, right? You know, it goes away in a second. By the time you see the dye is gone, that is your arterial. So because there are arteries in the epidural space, there are veins in the epidural space. So your tip of the needle can be in one of them. So you got to be very careful when you inject the dye. The dye spread should be thick and dense and not going away anywhere. And that's the epidural space. And it should not be intrathecal as well or subdural. This is the lateral view, right? See the dye, nice and thick and dense all the way across. It's going up. Epidural space. See the nerve root coming out? That's the nerve root coming out. So for the epidural steroid injection, this is what you do. First, get an AP view, identify your spot, write L5S1, put your marker, put your needle, advance it, use loss of resistance. Once you're there, inject dye, make sure you're in the right place, there you go. Epidural steroid injection. All right? Can't make it any simpler than that, right? Now coming to a little more difficult part of this, lumbar transforaminal epidural steroid injection. There are several approaches to transforaminals. I'm not going to discuss all those. I'm going to discuss one, the subpedicular approach, which was what I was taught under Dr. Gabor Rax. He taught me this procedure, and I personally feel it's good. Once again, you can look at other approaches as well and see what suits you, but this is one of the safer approaches to transforaminal injections. I'll describe that in detail. There's so many different names for. Can anyone tell me the difference between transforaminal and a selective nerve root block? Come on, guys, let's go. What is a transforaminal and what is a selective nerve root block? How are they different? There's a subtle difference where the needle tip is, right? The needle tip adjacent to the nerve root outside the foramen, it is called selective nerve root block. If the needle tip is within the foramen, you call it? Kya farak hai? 19-20 ka farak hai, right? They say, right? 19-20 ka farak hai. So there is not much difference. So if you look at the roots here, that's where your needle tips are. What is this? Is this a selective nerve root block or a transforaminal? This one here. What do you think it is? Transforaminal, right? It is going into the foramen. Several different techniques are described. I'm going to go with oblique, the subpedicular approach. So you position the patient prone with the pillow under the belly, and position of the C-arm, initial AP view of the lumbar spine, right there. Square the inferior end plate. You always square the plates. You know what the squaring the plates is, right? You understand what squaring the plates is. When the plates of the vertebral bodies are appear in a square, you know, they shouldn't be this way or this way. So they should be squared. So then an oblique view till the facet joint lines are visible. See that? Oh my goodness, this I've forwarded. What did I do? Okay, this is forward. Then you get a oblique view. You see the dog, right? Does everyone see a dog there? Yeah, so When I was in my fellowship, I mean, I didn't understand what the hell are they talking about dogs in the spine. But yes, once you train, see that is the ear, right? Snout. This is the body, the front leg and the back leg. That is called an Irish Terrier or a Scottish Terrier. So that's what the dog we are talking about all the time. We're going to talk about more dogs when we're doing medial branch blocks. So, oblique it till you see a facet line. See that facet line? See the line of the facet joint right there? That's the line. And Scotty dog view is obtained. The fluoroscope is maneuvered till the tip of the superior articular process of the level below is positioned below the pedicle of the level above. Okay, we are talking about this level, right? Are we going to call this L5? Yes? And see the tip of the superior articular process is almost below this pedicle here. Skin entry point is chosen immediately above the superior articular process. Immediately above the superior articular process. Skin infiltration is performed and the block needle is inserted and advanced down the beam, right? We are calling this gun barrel technique till bony contact is made within the inferior aspect of the pedicle. So you hit the inferior aspect of the sub-pedicular approach. That's why it's called sub-pedicular approach. And this is where you put the needle, pedicle, sub-pedicular. Always use a direction, depth, and direction technique. A lateral view is obtained, and the needle can be advanced in small increments to slide off into the rostral part, not the rostral part of the foramen, and with the tip in the mid or ventral aspect of the foramen. Actually, guys, it's more ventral than you guys think. When you put the needle in, it is actually more ventral than you think. So it's almost, look at where the nerve root comes out. So if paresthesia is encountered, what do? You reposition the needle. Why? If you don't, what happens? You'll transfix the nerve root, right? So you have no business doing it. So please be careful. That is the reason why the patient has to be awake and telling you where your needle tip is. So you cannot sedate the patient. They have to be awake. If they're awake, they'll tell you, yes, no, I feel it going down the leg. The moment they say that, please stop your procedure and just reposition the needle. A final AP view can be obtained with the needle tip lying inferior to the pedicle, right there. Okay? So this is the sub-pedicular approach for the transforaminal epidural steroid injection. After confirming the final position of the tip, aspiration is performed and half cc of contrast. You do not use any more than half cc. Even half cc is sometimes too much. This is not an interlaminar. You don't have the whole epidural space for yourself, right? You have a very little space, and what do you have next to you? You have the nerve root, so you're not going to put a lot of material in there. So you have a very little space there. The contrast should spread medially from the needle tip through the foramen around the pedicle and covering the segmental nerve with some epidural spread without intravascular uptake. There you go. Around the pedicle. Can you see the dye around the pedicle right there? And it's going to the epidural space and it's coming out as a nerve root without intravascular uptake. The local anesthetic steroid is then injected into a volume of no more than 1 cc to 1.5 cc is all you need for a transforaminal, because you're blocking only one nerve root, right? Your aim is not to do an epidural steroid injection. This is a transforaminal epidural steroid injection. Now, a slightly modified technique called RAX, because RAX is the one who designed it. RAX is the one who I trained with. So this is called the RAX technique. We were always taught to do transforaminals with blunt needles. I've never done a transforaminal with a sharp needle. I've never done one, because RAX put the fear of God in us. You will not take a sharp needle to a nerve root. So what do? You take an angiocath first, right? Insert the angiocath through the skin, take the needle out of the angiocath and use a blunt needle and go with the blunt needle. So if you hit a nerve root with a blunt needle, it is much less traumatic than a sharp needle. Why do I know this? Because I did a study with RAX. We took sharp needles and blunt needles and we poked the renal arteries of pigs. And that's a study we did. and 10 times out of 10, the sharp needle poked into the renal artery. The blunt needle only poked the renal artery 2 times out of 10. That's the study we did, me and Rax did. So we know that a blunt needle is far safer than a sharp needle. So transforaminals, once again, you know, I have always done it with a blunt needle, so it's always safer to do with a blunt needle, but a lot of people do it with sharp needles. So once again, you figure out what is good for you, what is safe for you. This technique follows most of the steps, the same steps, but the only difference is the target point is the ear of the Scotty dog, right? It's the ear of the dog, not let me see here. See that it's the ear of the dog, not the subpedicle, just a little difference, a very subtle difference there. Once you hit the ear, you turn the tip of the needle laterally and slip past, right? And then once your needle is past the tip, you turn the needle back into the foramen. So you go this way, your tip of the needle hits the bone, you go past the bone, then turn it back into the foramen. So you angle the needle back into the foramen. The needle is advanced till it pops through the intertransverse ligament. There's an intertransverse ligament there. You know, people say you can feel the pop. I usually don't because it's a blunt needle. It's difficult to feel that pop. Complications. Infection, epidural abscess, meningitis, bleeding. You can have an epidural hematoma, tissue injury, post-dural puncture, headaches, vascular injury, emboli leading to spinal cord, brainstem, cerebellar ischemia and injury, nerve and spinal injury. So once again, remember, you have an instrument, a lethal weapon in your hand. So you got to be very careful when you're doing these injections. Don't be cavalier about these injections. Just because you have a needle, you do not do a procedure. Just because you know how to do a procedure, you do not do a procedure. Why do you do a procedure? The only one reason. Tell me one reason why you do the procedure. Because the patient needs it. That's the only one reason why you do a procedure. Not because you're trained to do it, not because you know how to do it, not because you're good at doing it, right? Only one reason you do the procedure is because the patient needs it. And which do you think has more complications, an interlaminar or a transforaminal? By far transforaminal, by far. So be very careful. There are cases of spinal cord injury with transforaminal, so we are going away from transforaminals more and more. I've stopped doing any cervical transforaminals, and even lumbar, a neurosurgeon has to twist my arm for me to do I will ask him, why do you want a transforaminal? Because I can get the same result or a better result with an interlaminar. I can go in there, I can put more steroid in there, I can highlight that nerve root and 2 other nerve roots if I want to, but well, the neurosurgeon asked me, no, I want to see which level is affected. Okay, then I may do it as a diagnostic block, but even that, he has to twist my arm to do a transforaminal. So please be very careful when you're doing transforaminal. I want you guys to practice for the rest of your life. So be careful when you're doing these procedures. Paraplegia and hemiplegia also has happened with these injections. So now coming to the last part of the talk, lumbar medial branch blocks. We don't do the intra-articular injections anymore, right? Anand, I think Anand mentioned that we are not doing intra-articular injections because simply they don't do much. Instead of doing an intra-articular injection, what are we doing now? Medial branch blocks. They have replaced intra-articular injections. They are easier to perform and safer than intra-articular injections. The capsules of the facet joints are richly innervated with encapsulated and unencapsulated nerve endings coming from the medial branches of the dorsal rami of the spinal nerves. Each facet joint, I think Anand made this point. It's very important, guys, for you to remember each facet joint is supplied by 2 nerves, and each nerve supplies 2 joints. So these are the levels. So let's say if you want to block the L3-4 joint, so where do you put your needle? You block the L2 and L3 medial branches Where do you put the needles? At L3 and L4 transverse processes, right? So that's how it goes. It takes a little time for you to remember, but you can remember it once you get the hang of it, you'll start remembering it. So this is how the anatomy is. It comes out. This is the medial branch, and it drops down and supplies this joint as well. So that's the whole point of blocking two nerves. The medial branches of L1 to L4 assume a constant and similar course. Each nerve emerges from the foramen and courses around the neck of the superior radical process, right? See the dog again here? Can everybody see the dog? This is the what? This is the what? The ear, right? What is this? The snout. What is that? Front leg, back leg, and the only difference is the medial branch of the L5 dorsal ramus. Where does it go? It goes between the junction of the ala, the sacral ala, and the superior radical process, right? That is the only difference for the L5, the medial branch of the L5 dorsal ramus. How do you do the procedure? Position the patient prone with the pillow under the abdomen. Position the C-arm. Again, position, position, position. You get an AP view first, right? Then an oblique view till the facet joint lines are visible. AP view, then oblique it there, that way. Till the facet joint lines are, see, that's the facet joint line. That's the facet joint line. Facet joint line are visible. And you see the very famous Scotty dog, Scottish Terrier. So what is the Scotty dog? Let's split it up here. See the dog? That's your dog, right? So the ear is the, what is it? Superior process. What is the nose? Transverse process. Front leg? Inferior radical. And then the whole, this one, the body and the leg forms the lamina and the spinous processes. So that's your Scottish Terrier. Your target is the eye of the dog to block the medial branch. What needle do you use? A 22 to 25 spinal gauge spinal needle is inserted after skin infiltration with local anesthetic, and then you go, how do you direct it? Down the beam. See that? That's down the beam. That is a gun barrel technique with the tip of the needle guided toward the eye of the Scotty dog. See the Scotty dog here? Eye, eye, and eye. Till bony contact is made. And always use the 3D technique: direction, depth, and direction. A lateral view should be obtained to confirm the final position of the needle. So what is the final position of the needle on the lateral view? Here, see that? That's the facet line, right? That is the posterior element. You should not cross that line. That is the facet line right there. It should be below the disc, behind the foramen, right? Your needle has to be always behind the foramen. The final position of the tip of the needle should be behind the foramen and at the level of the facet joint on the lateral view. So that's the foramen right there, right? So aspiration is then performed in half milliliters. You don't need much. Contrast is injected and the spread should be posterior without any intravascular, epidural or intrathecal spread. If you go a few millimeters anterior, where do you go? Into the foramen, right? You can go into the foramen, just a few millimeters, and you are in the foramen. After contrast confirmation, the local anesthetic and steroid is injected. Finally, coming to the complications, all the same complications that we talked about, but much less in facet blocks than epidural steroid injections, because it's a much, you're not entering the epidural space, you're not going into the middle compartment, you're staying in the posterior compartment of the spine, the chances of injuring tissues are much less. And even if there is a hematoma, it forms in the posterior aspect. It doesn't go into the spinal canal, so the risk of spinal cord injury is much less with a facet block than with an epidural steroid injection. Brainstem injuries and stuff are much less with facet blocks. So that's about it. Thank you, guys.